So we'll go on to our next speaker. Dr. Pravin Krishna, are you there?
Yeah, he's there.
Yeah. Dr. Pravin Krishna is another cornea refractive surgeon who doesn't need no introduction, and he's one of the directors of the famous LV Prasad Eye Institute, where a lot of talent emanates from, and he heads the cornea and the refractive and the cataract and the contact lens services. And he's going to talk on a very interesting topic, interface challenges and solutions, and he's going to work magic talking all of it in 8 minutes. Or 10 minutes, I think.
Thanks a lot, Chitra, and amazing talk so far, and thanks for having me here. What I thought I will do today is actually speak on interface complication that is potentially not spoken about a lot, and briefly allude to the other interface complications that also tend to be confused with PISK or pressure-induced stromal keratitis. And because of the fact that this is an ARC session and there potentially are also going to be a lot of students, I thought I'll keep my talk a little basic and go back to the principles about why this occurs, and then talk about how to recognize this, and then talk about how to treat this and avoid it. So PISK or pressure-induced stromal keratitis is known by a lot of other names. It's also called interface fluid syndrome, PILK and PLEK at different time points. But probably the most appropriate name is still interface fluid syndrome, because neither is it a keratitis nor is it a keratopathy, and it is not something that is induced by edema. So let's step back and see what causes this condition, or IFS, and interface fluid syndrome. The fact that it occurs only in surgeries where there is a lamellar interface, like in LASIK, means that it requires an anterior lamellar interface to be present, and it does not occur in surgeries where you have a posterior lamellar interface, say for example in TSEC or DMEC or even in DLK surgery. So there are two reasons why you have interface fluid: either elevated intraocular pressure or some amount of endothelial dysfunction. So elevated intraocular pressure can occur after LASIK surgery because of a number of reasons. Could be because of steroid-induced rise in IOP, probably pre-existing missed glaucoma, and sometimes even uveitis that can occur after LASIK surgery. Endothelial dysfunction, again, typically occurs in most cases because of missed endothelial dystrophy, does not occur immediately post-op, could be because of endothelial damage, this has been reported as well, and very rarely a split in the Descemet's membrane, a case of which I'll show you a little later. So again, thinking about what is the structure of the corneal stroma and how does this lead to the development of interface fluid syndrome, all of us know that the stroma comprises mainly of collagen fibrils, cellular elements like keratocytes, and then an extracellular matrix in the cornea. But what is interesting about the fact that the cornea is not uniform? The stromal lamellae are distributed differently based on the depth at which they are present. The stromal lamellae in the anterior part of the cornea, as you can see in this histopathology section, are much more compact, and they're also much more intertwined. And this is the reason why you do not tend to get a lot of corneal edema in the stromal lamellae in the anterior stroma, whereas in the posterior stroma, they tend to be more parallel, and that is why they tend to be separated more easily if you have edema that occurs in the posterior stroma. And as most of us have noticed, even after cataract surgery, when you get folds on the cornea, these folds and the swelling on the cornea occurs mostly on the posterior surface, whereas there is only minimal change on the anterior surface of the eye. So why does increased intraocular pressure or endothelial dysfunction lead to fluid accumulation within the cornea? All of us know that the endothelium actually is a monolayer that has tight junctions, typically does not allow fluid to seep in between these tight junctions. But there is a metabolic pump in the endothelium as well, which also tends to reduce the amount of water and keeps pumping out excessive water from the cornea. And the cornea is about 90% water anyway, in most of the times. So there needs to be a balance that is maintained between the hydration that is present in the cornea and the two surfaces in front, that is the tear film and the aqueous lake that is behind. So anytime there is a disturbance in this homeostasis, where you have either an increase in the intraocular pressure or a reduction in the pump function, which pumps out fluid from the stroma into the aqueous humor, you tend to have accumulation of fluid within the cornea. And typically in eyes where you do not have an interface, like in bullous keratopathy after cataract surgery, or in Fuchs, most of this fluid either accumulates within the stroma or accumulates just under the epithelium, which actually is another potential interface. And this is again the similar mechanism where it tends to occur beneath the LASIK flap as well. So there have been studies done in iBank corneas after having a LASIK flap, looking at how much pressure will induce this kind of interface fluid. And they've also been staged into different stages. Like stage 1 is only a mild interface fluid syndrome. Stage 2 is moderate, where you start to see a symptomatic thickening of the stromal area with the interface haze and small fluid pockets as well. And then you have a symptomatic diffuse confluent pocket with sort of surrounding haze as well. So how is this recognized typically, and how does this appear when you examine a patient who has this issue? So most of us imagine that when you see or you expect to see a patient with interface fluid syndrome, you think that this is going to show up as fluid or stromal pockets within the stroma. But this is not entirely true. This only occurs late in the stage of the disease, and there are a lot of other signs that we actually can look for early in the post-op period. For example, this patient is somebody who underwent LASIK surgery, and this patient is somebody who had a myopic refractive error. And because of this, this patient had interface fluid syndrome later on. So preoperatively, you'll see that this patient had a low refractive error of about minus 3.5, and then this patient had a normal corneal topography. At the 1 week post-op visit, the patient had a very good correction and 20/20 at 1 week. But then the patient was lost to follow-up, supposed to come back after 1 month, but comes back after 2 months and continued to use steroids. And this patient, again, you see, has an area of steepening on the central part of the cornea with a decrease in the vision and an increase in the refractive error of the eye. And when you examine a patient like this, though the intraocular pressure on eye care tonometry, it's important that Goldman appellation tonometry might actually mislead you and get erroneous IOP readings. You have to take IOP readings from the periphery of the cornea or with a machine that is non-applanation, which is like your Goldman appellation tonometry. So you don't see any changes in the cornea. But then when you look at the topography, you'll see that at the 1 week visit, the average K mean was 41 diopters. And at the end of 1 month or 2 months, it is increased by almost 1.2 diopters. And this typically occurs because of raised intraocular pressure. So look for changes in the topography of patients as a first sign of interface fluid syndrome before you actually start to see fluid in the interface. Another way in which these manifest is this patient who had, again, a low refractive error of -4, no cylinder, pre-op normal topography, underwent LASIK, and then at post-op day 7, you see the patient has a relatively good correction, 20/20 in the right eye, 20/30 in the left eye, which again was the best corrected vision. And then at 30 days post-op, 1 month post-op, you see there's a drop in visual acuity, and there's a change in refraction as well with a myopic shift. So myopic shift is the other way in which you can diagnose these patients who have interface fluid syndrome, and you see that the pressure was about 30 millimeters of mercury in both eyes. But when you see this patient again at the slit lamp, you see that there's almost no change in the contour, no change in the interface as well that you'll notice in the slit lamp. And in this particular patient, there was no evident anterior central steepening of the corneal topography as well. And this is where OCT helps a lot. In OCT, typically you'll see an interface after LASIK, but then this interface is usually not very distinct. But if you have fluid accumulation around the interface, you'll see a stippled kind of appearance on the OCT that tends to lead you to suspect that there might be fluid accumulation within the stroma as well as within the interface as well. So this patient was diagnosed as IFS, started on oral Diamox, pressure went down, and you see that the visual acuity improved by itself to 20/20 with minimal correction at 45 days post-op. Now, how do you differentiate this from other interface conditions like DLK or diffuse lamellar keratitis? Now, diffuse lamellar keratitis, again, is an inflammatory condition that tends to occur in the early post-op period after PLSK or IFS. And several times, surgeons tend to mistake DLK with interface fluid syndrome because the appearance of both of them can be relatively similar. Now, this is a patient who has interface fluid syndrome, looks very much like DLK. So, and because intraocular pressure is erroneously measured to be low, the normal response is to lift the flap up and wash the interface, or to increase the steroids. So when you increase the steroids, the problem gets compounded. So one of the best ways to differentiate the two is to remember that DLK tends to occur in the early postoperative period in the first week, whereas IFS tends to be late. It's about 3 weeks or later. There is a change in the refraction and keratometry in IFS, whereas there is no variation in DLK. And on topography, there is steepening of the cornea in case of IFS, whereas there is no steepening in DLK. This can also occur after other surgeries that have an interface like SMILE. This is a patient who had SMILE post-op day 7. And if you look at the OCT, you'll see clear separation and fluid pockets at the interface after SMILE surgery as well. And has been reported in literature in several cases too. So this patient, preoperative topography before SMILE -5 with a low cylindrical correction, did very well in the early post-op period. So at 1 week post-op, you'll see the patient is 20/20 uncorrected, but again did not stop steroids and had a steroid response. So at 1 month, the patient becomes myopic and then the vision drops again. And this patient has a diffuse haze in the interface, and we diagnose this patient as interface fluid syndrome. As you can see, same kind of stippling on the OCT, which again led us to start Diamox, and eventually the patient got better. But sometimes if this fluid is present in the stromal or in the interface for a long time, it can lead to interface scarring, and this can lead to a hyperopic shift in the refractive error long term after the fluid has resolved as well. There also are scenarios where you have endothelial dysfunction, like in this patient who had LASIK about 10 years ago and then came to us with severe interface fluid, though she was doing very well in the early post-op period. And you can see that there is a lot of fluid collection and a flap with epithelial ingrowth as well. And if you look at the OCT carefully, you'll see there is swelling of the stroma as well, which indicates that this patient has endothelial dysfunction. And on specular microscopy as well, we could see guttae in the periphery of the cornea in the other eye. After endothelial transplant, DMEC, this actually resolved by itself and did not require any intervention. And this is the OCT after doing an endothelial keratoplasty for this patient. Similarly, you can have a combined etiology where this patient who had an iris implant had intraocular pressure that was elevated as well as endothelial dysfunction, and this led to interface fluid. This patient required a TRAB and then required a DBEC as well, and after both were done, patient again recovered to almost completely normal vision with no interface fluid after doing the endothelial keratoplasty. Last kind of scenario where this can also occur is in a patient who had post-LASIK ectasia and then developed hydrops in that cornea and had a LASIK flap, and so had fluid collection under the LASIK flap, and this had to be sutured because unless sutures were made, were put in, the split in the desmes would not have closed, and there would have been interface fluid for a long time. And this patient within a week actually resolved very well and achieved very good visual acuity correction after the surgery. So to summarize, IFS or PILK or PISK or PLEK needs an anterior lamellar interface, cannot occur after PRK, and usually occurs because of elevated intraocular pressure or because of endothelial dysfunction. Most common scenario that we are faced with after LASIK surgery is elevated IOP. So remember that do not just take IOP with a Goldman applanation tonometry. Also check IOP in the periphery of the cornea. Steroid-induced glaucoma is more common than we think. In fact, 1/3 of the population has been reported to be moderate responders by using steroids. And if you look at the risk factors, one of the risk factors is actually high myopia, which is where we do most of our LASIK surgery. Kind of steroids, dexamethasone, prednisolone are probably the most common causes, followed by fluoromethalone, and which is one of the reasons why we prefer to use loteprednol after surgery. But I think the best way in which you can prevent this is to use less steroids for a shorter duration and to be aware of what are the early signs of IFS after surgery. Thank you very much.
Thank you very much, Dr. Pravin. That was an amazing talk, and we just never cease to learn some more in some of your talks. So practical and relevant. I have a question, very simple. I mean, we've hardly had a pressure-induced stromal keratitis in spite of our large numbers, and it was a very transient event in one of my patients. But how long would we actually use anti-glaucoma medication in these eyes, especially when it is early on? Any of you have thought, like, when would you decide? 2 to 4 weeks is enough, you stop it? because anyway the IOP recordings are not very reliable, or when the slit lamp photo gives us or OCT tells us to stop?
Typically, because these patients require only short-term therapy, oral anti-glaucoma medications like Diamox tend to work quite well if they're tolerated well, and short duration, couple of weeks, like you said, and withdrawing the steroids usually takes care of the problem.
Okay. One thing which, because of the paucity of time, you couldn't cover, I would definitely take you on that some other time. Even if you've had a DLK, has anybody had an experience where they needed to do a second interface wash for some of these patients? And if you were to do a second interface wash for a DLK which has not totally gone, then what would be the kind of time interval? Would you do it immediately the next day, or would you wait for a time frame? This is for some of those very rare events of a severe DLK happening. Ramurthy, Gaurav, Dr.
We have
Mahika.
had occasions to do a second wash. I mean, it's been extremely rare, more during our microkeratome days, though I don't know whether the microkeratome or the femtolasic has any role to play in this. But when it has been recalcitrant and persistent, we have had to do a few cases. It has been the first wash did cause a little bit of subsiding of the interface inflammation, and then in spite of the steroids, when it did not subside, we had to intervene once more, and finally the results were reasonably satisfactory. Just one point in addition to what the excellent presentation that Pravin made was, another entity which can sometimes be confusing is the central toxic keratopathy. It's most important to differentiate between these three, simply because in DLK, steroids is the mainstay of treatment, and for PLK, if you use steroids, you're going to worsen the condition. And with central toxic keratopathy, though the picture looks quite devastating, frankly, no treatment is needed. I mean, just with observation, though it takes some time to resolve, steroids may not worsen the condition, but even without that, the condition is likely to resolve over a period of months. Any comments on this?
I think we are running short of time. Sorry. Just one more question I have for the expert, and Srital, you start sharing thing. Supposing you have a hyperopic shift after a CTK, as Dr. Ramurthy has discussed, has anybody done a treatment for that, or have they also regressed with time?
You
should not.
You should not. They generally regress with time. I don't think you really need to do.
Yeah, absolutely.
No
In fact, you should not touch it. I mean,
Okay. I think we are running late, though.